Good morning, everybody, and welcome to the IASLC World Conference on Lung Cancer's press briefing for the Presidential Research Symposium. My name is Jarushka. I'm the incoming chair of the IASLC Communications Committee and a thoracic medical oncologist. Thanks for the opportunity to be here. The press conference is going to cover the very best science from the World Conference on Lung Cancer, and congratulations to our presenting authors for their excellent submissions. These were selected as the top abstracts from over 1,800 submitted abstracts, and we're privileged as well to be accompanied by a lung cancer patient advocate on my right, Mr. Angus Pratt. This morning you will hear an update first about the TALENT study, which underscores the power and effectiveness of lung cancer screening. This will then be followed by new data on the Mars trial in mesothelioma, and then the FLAURA2 trial in EGFR mutant lung cancer, and then the staging or updates on pathology classification as our last presentation. Please hold your questions until the end of briefing, or feel free to type them into the chat box and we'll be able to get to your questions. So to present the first study, the TALENT study, the lung cancer screening study from Taiwan, I have Dr. Yang with me. Dr. Yang is a chair and professor at National Taiwan University, the former president of the National Taiwan University and member of Academia Sinica, World Academy of Science, and the National Academy of Inventors. His research interests are lung cancer genomics and precision cancer therapy, and he received the 2020 IASLC Joseph W. Cullen Distinguished Award for his contributions to leading in the field of lung cancer screening, and we're very privileged to hear from him today. Thank you very much, Professor Yang.
Thank you. Good morning, everyone. It's really my great pleasure to share with you the early detection program for lung cancer in Taiwan. As you know, that Asia has highest disease burden of lung cancer in the world, 60% of incidence and 62% of cancer mortality. There's very high prevalence of non-smoking lung cancer in East Asia. If you estimate nearly more than 30% of lung cancer patients, actually, they did not have smoking history. So family history, in our previous study, we showed that family history may increase the risk of lung cancer. There's a need to reduce global lung cancer mortality. We need to expand the screening eligibility to cover non-smoking lung cancer. The TALENT study, the detection rate first round is around 2.65%. Even the invasive lung cancer is 2.14%. 96.5% of them are stage 0 to 1. The meta-analysis and the cost-effectiveness studies support the low-dose CT screening in non-smokers. The TALENT study show you that the family history may increase the risk of lung cancer. We have another cohort. We follow up lung cancer patients in those with family history. You can see that the cumulative lung cancer detection rate in those subjects with family history up to 4.5% in 10 years follow-up. In simplex, it's about 3.4%, and in multiplex, up to 7.7%. This is the fact of lung cancer in Taiwan. Lung cancer is the leading cause of cancer mortality in men and in women. Non-smoking accounts for nearly 2/3, 66.3% are non-smoking lung cancer, and smokers only around 1/3. Very high female to male ratio. Adenocarcinoma accounts for 70% in female. More than 94% of them are never smokers. And stage 3 and stage 4 disease, more than 60%. This is why we study Taiwan early detection program for lung cancer start from July 1st, 2022 until June 2023. This is a 1 year's result. The study aimed to double the stage 1 disease and 5-year survival by 2030s. This is a biannual low-dose CT screening program for high-risk sector. We focus on 2 groups, the smokers, 30 years, 50 to 74 years old, agreed to quit smoking or have quit smoking within 15 years, and non-smokers with family history of lung cancer, especially female, 5 years younger, start from 45 to 74 years old, and in male, 50 to 74 years old. You can see the result here. We already screened 49,500. And you can see the lung cancer detection rate in overall is 1.1%. In those with family history, up to 1.4%, and those with heavy smoker is 0.6%, both 0.9%. Most importantly, 85% of them are stage 0-1. They are potentially curable. Thanks for your attention.
Thank you very much, Dr. Yang. Any questions from the press about this presentation? Welcome you to come up and or to raise your hand if you have any particular questions. Okay, no problem. Okay, we can move to the next presenter then. So the next presenter is Dr. Erik Lim, who will be discussing his research MARS-2, a multi-center randomized trial comparing extended pleurectomy and decortication versus no radical surgery for mesothelioma. Professor Lim is a consultant thoracic surgeon at the Royal Brompton Hospital and the professor of thoracic surgery at the National Heart and Lung Institute of Imperial College London. He is the national chair for thoracic academia with an active interest in clinical trials, serving as the chief investigator of MARS-2, the VATS lobectomy study Violet, and a study on local consolidation treatment for advanced lung cancer, Ramon. Thank you for joining us, Dr. Lim.
You're not here.
No problem.
Thank you. Thank you very much. Surgery for mesothelioma is currently offered across the world with extended pleurectomy decortication to remove all visible disease, recommended by American guidelines, European guidelines, as well as international consensus statement, despite never being evaluated in the setting of a randomized controlled trial. The UK mesothelioma research investigators conducted a randomized trial comparing the clinical and cost effectiveness for this operation for mesothelioma. We screened over 1,000 patients and randomized 169 to surgery and 166 to medical treatment alone. And we reported that the patients who were allocated to surgery had a 28% increase in the risk of death. In addition, complications were all serious complications occurred at 3.6-fold higher for patients randomized to surgery. An operation like extended pleurectomy decortication for mesothelioma would be associated with a poorer quality of life. But for every single outcome that was statistically significant in all scales for the EORTC, QLQ-C30 were against or poorer for patients in the surgery arm. In addition, when we take death into account, we see the full effects of the morbidity of the operation or impact on quality of life, because in this case, death is weighted at a 0 outcome, showing much worse utility with patients who received surgery. In order to improve outcomes for patients with early stage mesothelioma, stopping surgery would improve survival immediately by 28%. But if the thoracic oncology community can give up the concept of resectable disease, we would then be able to open access for effective treatments currently licensed for unresectable disease. So in conclusions, the MARS-2 trial demonstrated that surgery in the form of extended pleurectomy decortication for mesothelioma had worse survival, more serious complications, poorer quality of life, and higher cost compared to chemotherapy alone. Thank you very much.
Dr. Lim, any questions from the floor before we move to the next, and keep any online questions for the end?
I won't be able to stay to the end.
Okay. Okay. Dr. Lim won't be here at the end to take questions directly. So if there are other questions, then we can always chime in if they come in. All right. Thanks so much. I'll now move on to our next speaker, Dr. Janne. Dr. Janne will present Osimertinib with or without platinum doublet chemotherapy as first-line treatment in patients with EGFR mutant advanced non-small cell lung cancer, the FLAURA2 study. Dr. Janne is the director of the Lowe Center for Thoracic Oncology at the Dana-Farber Cancer Institute and a professor of medicine at Harvard Medical School and the David M. Livingston Chair and Dana-Farber Cancer Institute. He's also the director of the Balfour Center for Applied Cancer Science at Dana-Farber. His main research interest is in translational medical oncology, specifically in EGFR mutant lung cancer. He's received many previous awards for his work from the AACR, ESMO, ASCO, and we're pleased to have him present today in the presidential session of IASLC. Thank you.
Thank you. Happy to present the FLAURA2 clinical trial, which is a randomized trial of osimertinib with or without platinum-based chemotherapy as first-line treatment in patients with advanced EGFR mutant non-small cell lung cancer. It's funding and so for patients with advanced EGFR mutant lung cancer, EGFR TKIs are the standard of care. Osimertinib, which is a third-generation EGFR TKI, is the preferred first-line treatment for advanced EGFR mutant non-small cell lung cancer based on the prior FLAURA trial, which demonstrated superiority in PFS and OS compared to earlier generation EGFR TKIs. However, despite osimertinib's efficacy, most patients, unfortunately, will develop disease progression at some point during the course of their treatment, and hence, which has led to the idea of doing combination studies. And prior clinical studies suggest that even with the first generation EGFR TKIs, the addition of chemotherapy has a potential benefit. In single-arm trial of osimertinib with chemotherapy in the Japanese phase 2 OPAL trial demonstrated encouraging clinical activity, and the FLAURA2 trial tested this in a randomized setting. This was the design of the trial. There was a safety run-in to make sure the chemotherapy and osimertinib were well tolerated, and the answer was yes, and it was published in ESMO Open in 2021. Inclusion criteria for patients, advanced EGFR mutant non-small cell lung carcinoma harboring the common EGFR activating mutations, good performance status, stable CNS metastases, either treated or asymptomatic untreated were allowed, and all patients had baseline CNS imaging, stratification factors in the middle. And then patients are randomized in a one-to-one fashion to single-agent osimertinib or to the combination of osimertinib and platinum-based chemotherapy with cis or carboplatin and pemetrexed for 4 cycles, followed by pemetrexed maintenance with osimertinib. Primary endpoint was PFS by investigator assessment in this study. And these were the data. In the combination arm, both by investigator assessment and by blinded independent central review, had a significantly longer progression-free survival compared to single-agent osimertinib, 25.5 versus 16.7 months, or 29.4 and 19.9 months, both with highly statistically significant p-values. The progression-free survival benefit was seen across all predefined subgroups, including age, smoking status, EGFR mutation type, performance status, presence or absence of CNS metastases at baseline, gender, and race. Safety summary: with the addition of chemotherapy, there were more as not unanticipated adverse events, and you can see those summarized here. And those that are causally related to treatment. Any adverse events greater than 3 were higher in the combination compared to the monotherapy. And whether they're causally related to osimertinib or the chemotherapy components are shown on the bottom as well. Fortunately, adverse events leading to death were very low. And in the combination arm, patients received a median of 12 cycles of pemetrexed, and 2/3 of patients, 76% three-quarters completed 4 cycles of the induction platinum-based chemotherapy, and the exposure to osimertinib was similar in both the single agent as well as the combination arm. And so these are the conclusions from the trial, that the combination demonstrates a statistically significant and clinically meaningful improvement in PFS over single agent monotherapy with a hazard ratio of 0.62, and you can see the absolute improvements here. By investigator assessment, about an 8.8-month improvement, and by independent central review, about 9.5-month improvement. PFS benefit was consistent across all predefined subgroups, and safety profile in the combination. Or safety profiles were as expected for each treatment and were manageable with standard medical practice. And there's a number of ongoing additional analyses from this trial that we hope to present at upcoming medical meetings over the next year. And I think our trial demonstrates that this is a new first-line treatment option for patients with EGFR mutant advanced non-small cell lung cancer. That's it. Thank you.
Thanks, Dr. Janne. Any questions from the floor while we're here? Okay, we might move on and then take more questions at the end. So our final presenter is Dr. Erik Thunnissen. He presented in invasion or non-invasion. That's the question. A large reproducibility study in pulmonary adenocarcinoma supporting a modified classification. Dr. Thunnissen is a long-standing member of the IASLC, joined the board of directors in 2019 and has served on the IASLC pathology committee, where he has led reproducibility studies for diagnostic pathology relevant to the WHO classification. Currently, he is a research pathologist in the Department of Pathology at the Amsterdam University in the Netherlands. Prior to this role, he served as a pathologist at both VUMC, Maastricht University, and Canisius Wilhelmina University. Dr. Thunnissen has authored many peer-reviewed publications and book chapters on lung cancer, and we're very pleased to have him present today. Thank you.
Thank you. This study deals actually, is a large study by several collaborators and 42 pathologists. It's the largest reproducibility study to date, covering pathologists from all major areas in the world. The clinical relevance is that patients with adenocarcinoma in situ, when resected, are cured, as opposed to those patients who have invasive adenocarcinomas. These will have a risk for a recurrence. Invasive measurement is relevant for staging, and in situ carcinoma has been described already in 1995. However, the diagnosis of invasion is a challenge. It has been shown by the pathology panel of the IASLC, and it has a low concordance. The study itself is a case control study comparing the WHO classification with a modified classification in resected pulmonary adenocarcinomas smaller than 3 centimeters. In total, 70 cases were examined. From each case, we had 3 stains. The routine one, hematoxylin eosin, an elastin stain, demonstrating if there's elastin that it is present from the alveolar wall and therefore the lung, and a cytokeratin 7 stain. All the slides were digitized, placed on the web, and pathologists from around the world could read these slides. In the end, we performed also biomarker analysis trying to validate the results. The main results are that if we read according to the WHO classification in round 1, the kappa score is 0.27. And it's good to realize that the kappa score ranges from 0 to 1. 0 is as good as flipping a coin, and 1 is 100% concordance between pathologists. In the second round, which was performed after a tutorial of 1 hour on the modified classification, the kappa score is 0.46. And the third round was performed after feedback from all the information from the peers, the 41 other pathologists, on their results, and then it shows the potency of the modified classification. If we break down the data more granular, then the cases are vertical and the scores of the pathologists are horizontal. Green is a score of no invasion, purple is invasion, and yellow is not sure, and red means those patients have a recurrence. And you see when you judge it across the world, there's a high variation across cases and across pathologists. And if you then look at round 2 and round 3, and in the end, in round 3, you see getting towards a concordance, more green unanimous on the left. And we also asked in the third round the pathologists how certain they were about the decision of invasion. And when they were very certain it's green, and that you see that the easy invasive cases are on the right, all pink, and marked with green. And on the left side, you see that when it's black, the uncertainty is high, and that deals with the part where invasion was an issue, yes or no. We measured also the variation when we measured total tumor size with a ruler, and the variation between all the pathologists is only 6%. So when we know what we have to measure, those pathologists can do it very accurate and precise. And if we look at the coefficient of variation in invasive size measurement, the variation is much larger, 42%, with a high standard deviation. And this is exactly in line with a recent paper published by the pathology panel of the IASLC. And in this study, it's new a type of analysis, that's a heat map analysis showing the area of invasion and the concordance in it or not. And if it's red and round, that area is shown by all pathologists to be invasive. On the left side, you see an example of it. And this invasive size is almost the same as the total invasive size. And then the variation in the measurement is low. In the middle, you see an example of a heat map analysis where you see all the colors of the rainbow passing. And when you go from red to orange to yellow, green, and blue, less pathologists assigned those areas. So underneath the red round area is a small histological area, which is a true invasive size of 2 to 3 millimeters. That's important. This patient also had a recurrence. And in the WHO classification, you score this as minimal invasive adenocarcinoma, but in the modified classification, it's not appropriate to do this. And you see on the right side another example. And in the third round, that's the most right image, you see different colors, but you see not a round red summary. And that denotes that the area of invasion assigned by these pathologists differs. This case had about half of the pathologists who assigned invasion, and the other half assigned no invasion. So it means that there's variation in size and location of the assigned invasive areas. In other words, the pathologists are uncertain and do not always perform the same. So when we use the WHO classification of pulmonary adenocarcinomas, there are now 2 independent studies showing the same. In terms of learning theory, it's then justified to say that when we use that classification, we are conscious incompetent on assigning invasion. On the modified classification, I think it's too detailed to discuss here, but suffice to say that if you have a small layer of tumor cells on the alveolar wall and a lot of air, as you can see on the lower left side, then it's in situ. However, what happens, and I like to explain you why the variation occurs. You see on the left side a CT scan with the normal width of the lung. And when it arrives at the pathology, we get a much smaller specimen in the width. And that implies that the air goes out. It's done by the surgeon. A lot of blood is out and a lot of lymph is out. And what happens then? And therefore, I took a kind of basket with me to show you the thinking. And this thinking evolves only in 2022, while the WHO classification we are using now was already made in 1999. If this box represents an alveolar volume, that is the smallest volume we use for breathing, then it has a surface on 6 sides, and in the middle there's air. If the surgeon takes for the whole lung the air out, not for the individual alveoli, we see that we need to reduce the volume of the alveoli. We need an adaptation. So at least a few of the sides need to fold because the total surface of the alveolar walls will not reduce during the deflation process. awareness of this, that then you realize that the underlying morphology is changing during the section. There's no other organ where this takes place. And in the middle, then there's an example of the collapsed in situ carcinoma. Well, in the WHO, it's not recognized. So therefore, 9 out of 10 cases of this series was overdiagnosed as invasive adenocarcinoma. And for the pathologist as an aid, when you use the elastin stain, the elastin fibers in the lung are present in a 3-dimensional meshwork. You can see the 3 dimensions there, it's just from a net. But if you cut through it, you will only see small fragments of these fibers. And that are the black fragments on the lower right, marked with a yellow arrow. And when that's there, the elastin is from the alveolar wall, and that structure is not from an invasive tumor. So that's a clue which helps the pathologist and was used in this study. And to see the difference with a true papillary carcinoma, you see on the upper right, true papillary carcinoma, no elastin at all, and also no elastin in the vessels of it. So we tried to validate these results. We made a division according to the modified classification, and then we attempted molecular analysis. On the first part is individual proliferation rate for those cases. You see the adenocarcinoma in situ, AIS, which have a low proliferation rate. They don't grow so fast. In contrast, those cases, the patients which were assigned with invasive tumors, their proliferation rate was much higher. Tumor mutational burden is a measure showing how many mutations are acquired in the tumor during the development of the tumor. And that's much lower in AIS. It means it's malignant, but has not so many mutations. If you've got more mutations, you've got more invasive potential. And we see a similar distribution in tumor mutational burden as in the proliferation rate. And lastly, mutations in P53, when present, are usually only present in the invasive cases, and that's in line with the literature from other studies. So the modified classification is supported by the orthogonal molecular analysis. So the conclusions are that with the modified classification, we are uncertain but competent, and this classification has an essentially higher reproducibility than the WHO classification. And awareness of the morphological consequences of iatrogenic collapse is important. And more training in the modified classification, as shown in the third round, will probably improve the reproducibility further. And the orthogonal biomarker analysis supported this modified classification. And thank you for your attention.
Thank you very much, Dr. Thunnissen. I'm just going to introduce our last speaker, and then we'll have a switchover of chairs to Dr. Stiles. So our last speaker is Mr. Angus Pratt. He's a patient advocate. We include an IASLC patient advocate to help to put our morning's research into a clinical context from a patient's perspective. Angus was diagnosed with male breast cancer in 2018, and then subsequently a primary stage 3 lung cancer, for which he underwent chemoradiation and durvalumab, and in the meantime, surgery for breast cancer. After that, he has been on targeted therapy for afatinib and remains very stable and well. He is our patient advocacy lead and mentor, has an extensive background in patient advocacy and mentorship through cancerconnection.ca, helped with several patient-led studies through Lung Cancer Canada around COVID-19, practicing in the groundbreaking Wrong Question campaign, and recently completed the STARS program with the IASLC, where he is a well-renowned patient research advocate, and we're very pleased to have him with us today. Thank you, Angus.
Thank you for that kind introduction. Before I begin, I want to, first of all, thank all of you for the wonderful research you do and have done for us as patients. I think too often you are hidden behind the scenes, and we don't get exposed to the wonderful work that you do. The second thing I want to say is I wish we had more money for you, and I want to work on that. There was an ask this year to the US government to increase the funding for lung cancer research to $60 million. We managed to get it increased to 25 million. As a Canadian, I have to acknowledge that those are American numbers, and I don't have global numbers, I'm sorry. The other thing that I want to make you aware of this morning is that this is a disease that kills, and I'm having a hard time standing here this morning. As I was watching this presentation, one of my fellow researchers, a participant in the research project that I presented yesterday, passed away. And I got word this morning during this presentation. So it's a challenge sometimes to be up here and speaking in these moments. The final thing that I want to say is as I'm listening to all of these presentations, I'm hearing my statistics professor from a few years ago, I won't tell you how many, who is talking to me about beta error, and the way he used to define it is to say, we don't know what we don't know. And I think that that's so true of so much of the research that we do. And I think that that is a theme that carries through the discussion that we've had here today. First of all, and then let me quickly address each one of the research projects that have been presented here today from a patient perspective. First of all, early detection. Most of us that are involved in advocating for more screening, the catching of this disease earlier, knowing that it has such a positive impact on patient outcomes, have been frustrated by what has been a box for us in terms of the smoking stigma, the smoking criteria that have been applied to early screening. And so the Taiwanese study really has turned that box into a bubble, and we're starting to break out of it. And it gives us the opportunity to look at some of the other factors. This is exciting because for those of us who haven't qualified and wouldn't qualify for screening, it starts to open those doors to that kind of a change. So thank you for that work and for the difference that it's making. Dr. Lim, Pleurectomy. I have fun with those words. It really does, for me, the message that I heard was the importance of checking our assumptions. The part that I heard was that this had never been checked from a randomized control trial before, and that is how we advance science. And to hear a surgeon with the humility to stand up and say that, as a surgeon, it pains me to say that surgery might not be the best answer here. Those are the kinds of statements that are going to advance science and advance treatment. And one of my friends likes to say, if you aren't failing 50% of the time, you aren't trying. And to me, those are the kinds of things that we learn and the kinds of things that change the way we approach this stuff. I have to announce when I start talking about Osimertinib that there is a conflict of interest here. I tried desperately to get it and didn't. I am on a drug called Afatinib, and that's and I've participated. I've been involved. AstraZeneca has supported me in my battle to try and get it. But to see this study, there are some questions. One of the major questions from a patient perspective, I would have to say, is it is exciting to see improved PFS, but we want to live longer. We want to see those overall survival statistics, and I think that that's important. We've seen some cases where PFS looked really good, but OS was not as good. I think the other question that comes up around this particular study is the idea that I'm happy, I just have to take a pill every day. I can do things like this, come to Singapore and not have to worry about scheduling it around my infusions. With a chemo treatment, you are tied down to every 3 weeks, you have to be at a clinic to get a needle stuck in your arm. And so those sorts of things are important to patients. And I think that seeing significant advances in quality of life are also important, along with simple overall survival. And I appreciate the fact that these things are being taken into consideration. And as again, this is exciting research. I think these combinations are going to prove to be part of the answer for much longer lives for those of us with EGFR positive cancer. I had not realized until a presentation that I sat in yesterday how important staging is to treatment. And so when we start talking about invasion and the challenges of determining whether that's happening or not, it's a very subtle distinction, but from the patient perspective, it determines our treatment. And those are the sorts of things that we need to be paying a lot of attention to as patients, and come to understand that the simple, we get handed a number, well, sometimes it has some letters after it, and we're told this stage, and this is the treatment that you're eligible for, or this is the treatment that you're going to get because you're at that stage. And to realize that that number has this incredible complication and that determines what that number is really important for us. And I think a lot more patients need to be aware of the uncertainty and the challenges around that. And again, to see the research that's happening in reducing those uncertainties is just really exciting for me as a patient. And so again, thank you for the wonderful research that you've done and for the work that you're doing to improve our lives. Thank you.
Hold on, just thanks, Chris. We have a journalist online that's asking, Dr. Thunnissen, can you provide a reference detailing the modifications to the WHO classification? And can you provide more details on what was happening in each round?
I understood the first question, but the second one?
Providing more details on what was happening in the different rounds of the classification.
Yes. Okay, then first, in round one, this is just as described in the WHO classification. And in the second round, they should not use the WHO, but use the concept that if you have a tumor that grows on the alveolar walls, this tumor respects all the pre-existing structures without invading it. That was the bottom line, and that's facilitated by a cytokeratin 7 staining, because then you see a regular pattern. And if you want to confirm that it's alveolar walls, you can also use the characteristic of elastin in these walls. So that gives you more comfort in making a diagnosis. And if all these structures are respected, then it's not invasive. So it fits with the diagnosis of AIS. Further, there are some subtle additions added. We have if you have a criteria which fits with invasion, we made a distinction in true invasion, growing really in a vessel, in a bronchus, in a septum between two lobules, or in the pleura, or in the interstitium. For the pathologist, that's true invasion. That's the one criterion. And the other one was if there is growth in the alveolar space. I showed you the box. Sometimes the tumor grows in that space and it's filling the whole space. But then you can still see at the outside that it was an alveolar wall because the elastin was there. So within this space, you can have some patterns where it's small and tufty of micropapillary, or that it's almost completely filling, and that we called surrogate markers of invasion. And the interesting thing is that if you look at true invasion, that in fact all patients with a recurrence were present, except for one, in the true invasive ones, where you expect to have it reached towards the small lymph vessels. Those are the vessels which take care of removing some interstitial fluid to the rest of the body. And if that has been done before resection, then there's a chance for a recurrence. You don't know if you get it, but that's why what's in essence in the modified classification. And if you want more details, then it's currently submitted for publication. So it's under peer review, as it's called, and goes to a journal, and other people, pathologists, look at it, and then they give their opinion, and that's what we are waiting for. So I cannot give you more details than that.
Thank you so much. We have another question here.
Thanks, everybody. Dr. Yang, for the press, could you put it in context again, the differential effects in men and women in developing cancer in your study, the rates of cancer? And then in your opinion, does that reflect a different biology of lung cancer in women?
Yes, actually, non-smoking lung cancer is a totally different disease. In our previous proteogenomic study, actually, you can see the driver mutation pattern is quite different. We have very high EGFR mutation compared to those with smoking-related lung cancer. And you look at the genetic susceptibility, they are also different. And we also identify, especially those non-smoking lung cancer, they tend to occur younger and have family clustering. And in those young female lung adenocarcinoma, they did not have smoking history. We do identify the alphabet signature that is associated with the occurrence of these young female lung adenocarcinoma. Another very important factors would be the environmental factors. We identify the carcinogen signature, especially PM2.5 related carcinogen signature, the polycyclic aromatic nitropolycyclic aromatic hydrocarbon, which is commonly present in the air pollution. Another one would be the nitrosamine, which is commonly used as a food preservative in Eastern Asian region. We saw that probably some endogenous factors and some environmental factors play a very important role. That's why we have so many EGFR mutation, and the tumor grows very indolent and grows slowly. But the instance of the adenocarcinoma in non-smoking lung cancer is actually increasing, not only in Eastern Asia, but worldwide.
Yeah, hi, Roy Herbst from Yale. I have a question for Dr. Janne. Congratulations on the presentation. I have a question in that, 20 years ago, we combined chemotherapy with EGFR inhibitors, and we saw evidence that there was progression-free survival benefit. That was the Tribute trial. That was before mutations. And now I think the fact that you're seeing this benefit is great, but having heard from Angus and others, it's going to be for selected patients. So my question is, you implied, and you've talked here, that there might be certain groups for whom this might be more useful for. And are there other markers besides the EGFR mutation that can be used? Can we look at DNA in the blood? Can we look at other factors? You also only looked at 2 different mutations in this study, but we know there are other mutations, exon 20. You have to think that this could be applied in specific situations.
Yeah, thanks. Thanks for that question. Absolutely. I don't think that the study included, of course, the common EGFR mutations that are found, the exon 19 deletion and L858R, where there's approval in common use, of course, of Osimertinib. But we do know from other studies that other genetic alterations that arise concomitantly in EGFR mutant cancers, so for example, P53 mutations and others, may modulate the efficacy of EGFR inhibition or how long patients remain on EGFR inhibition. And those are some of the things that are being currently looked at in this study. And similarly, if you detect EGFR mutations circulating in DNA in the blood, and if you clear those or don't clear those, meaning that if it's present there prior to treatment and it's still present 3 or 6 weeks after start of treatment, that tends to predict for a shorter progression-free survival than if it's no longer detectable. And we're looking at those analyses currently, and we'll hopefully be able to present those later on this year or next year. So yeah, you're right. It is trying to understand the clinical and molecular features really of individuals who are most likely to benefit from the combination of chemotherapy. I think the study shows that if you use the combination in all comers, you can show a benefit, but it doesn't at the moment. And again, this study and future studies will help, I think, refine the population most in need of chemotherapy and most likely to benefit from chemotherapy.
We have one last question here. I know we're running up to time.
Thank you. So I have a question for Dr. Janne. We saw an incredible benefit in these patients with CNS metastasis, and I think that's very relevant to many of our patients. My question to you is, now that we have this, these patients are high risk, they have worse prognosis. What would be the role of radiation as it slowly is fading as we're having more and more response in the CNS with systemic disease?
I think role of radiation still remains for patients with CNS progression in lung cancer, including EGFR mutant lung cancer. And I think it depends on what that looks like in the CNS. Is it a solitary lesion that gives rise to symptoms and, you know, where surgical removal or radiation may be appropriate? I think for more extensive involvement or numerous brain lesions, we're of course delighted for our patients that we have therapies that are active and can cross the blood-brain barrier. And we will, from this study, have a more extensive CNS analysis forthcoming as well, looking at and comparing responses in the brain to single agent versus combination as well. So having pharmacologic options to treat brain metastases is certainly something that we as a community aspire for, given that there are long-term consequences of radiation as well. I don't think radiation is going away because we do need it in several circumstances, as I already mentioned.
Well, thank you so much. Thank you so much. Thank you so much for being here. We have a few more questions online. We've run out of time. We'll make sure that we get those questions to you guys directly afterwards. But thank you for the work that you're doing. Thank you, journalists, for being here. And that's it for the Presidential Symposium press briefing. Thank you.
Thank you.